Dear students, I am Dr. Indra Priyadharshini, Associate Professor, Department of Oral Pathology, Vinayaka Mission Shankaracharya, Salem. Today I will be talking about the epithelial pathology, malignant part. Oral squamous cell carcinoma. It is the sixth most common cancer worldwide. In India, it is the second most head and neck cancer. It occurs in 90% of the patient. The risk of oral cancer that increased with age, especially for males. The multifactorial etiology, it plays a major role. Both eccentric and intrinsic factors plays a role. Co-carcinogenesis for this progress. Etiology, the tobacco smoking, smokeless tobacco, betel nut chewing, alcohol, radiation. The radiation, the sunlight exposure, it mainly causes the mammalian cancer and X-ray radiation. Coming to the main etiology, general malnutrition, that is iron deficiency anemia and vitamin A deficiency. The infection like syphilis, candidal infection and oncogenic virus and immunosuppression, oncogenes and tumor suppressor genes. Coming to tobacco smoking. Tobacco smoking 2 to 3 times more risk in smokers than the general population. It increased the risk of secondary primary carcinoma in upper digestive tract, more in pipe and cigar smokers. It is the depend upon the dose of dependent and increased risk with more cigarettes and longer duration of the habit. The higher risk in reverse smoking. In non-smokers, the squamous cell carcinoma, it occurs mainly in the tongue and floor of the mouth. The young females and mutation in tumor suppressor genes. Smokeless tobacco, the 4 times risk than a general population. 50% of the cancer that occurs in the site of habitual placement of smokeless tobacco. It mainly consists of betel nut and slake lime. It enhances the absorption of molecular of the products like areca nut, betel nut and tobacco leaf. 8% the risk of development. Alcohol, the synergistic effect with the tobacco. It acts as a potentiator that promotes for the other causative agents. It risk in dose dependent and time dependent, how frequently you take. With the tobacco, the risk is 5%. It causes liver cirrhosis, it could be seen. With phenols, it increases the risk of nasal and nasopharyngeal cancer. Coming to radiation, the X-ray radiation during the radiotherapy and UV rays from the sunlight. The risk of development of new primary oral malignancy. Its effect is dose dependent. UV plays implicated for the lip cancers. It mainly occurs in the mammalian border of the lip. Iron deficiency anemia, in severe chronic form, it's called Palmer-Vincent syndrome. It increased risk of squamous cell carcinoma in posterior part of the mouth and oropharynx and esophagus. It develops in earlier age in altered functioning of epithelial cell leading to atrophy. The presence of esophagus webs. Vitamin A deficiency leads to excessive keratinization as a protective role. In deficiency, there is an increased risk of squamous cell carcinoma. Coming to the infection, the syphilis, the tertiary syphilis is strongly associated with development of oral squamous cell carcinoma in the tongue. 4% of risk occurs during syphilis. There is a rare today with advent of effective antibiotics. So candidal infection, it could be a superimposed on existing precancer lesion. It could produce the nitrosamines that can promote the carcinogenesis. Oncogenic virus, that is human papilloma virus, HPV, that is HPV 16, 18 and 31, 33 plays an important role to cause the oral squamous cell carcinoma. Herpes simplex virus, that is type 2. These agents could interact into the host DNA and alter the regular growth and proliferation and may immortalize the infected cells. Immunosuppression, there is a lack of immunological surveillance and attack. The malignant cannot be recognized, detected at the early stage. The patient with AIDS and chemotherapy for malignancy or transplants are at the increased risk of oral squamous cell carcinoma. Coming to the genes, oncogenes and tumor suppressor genes. The proto-oncogenes are present in normal cells. They regulate the cell growth. The proto-oncogenes that activated by the viruses, radiations or chemicals in the form of oncogenes which stimulate the excessive protection of new genetic material. The tumor suppressor gene that regulate this growth and lack of genes that can lead to malignancy. The tumor suppressor gene that cause a cancer, that is RAS, MYC and P53 and PRB and E-Catherine, that is multiple mutation that affecting the interrelated components that related to malignancy. Coming to the clinical features, it's usually in older men. Minimal pain duration at the early phase. The present as a exophytic growth or endophytic growth. The exophytic growth as a mass, it looks like a fungative or papillary or verrucous. The color, it's depend upon the amount of keratinization and vascularity. Exophytic growth, that is burrowing or ulcerated. It depressed an irregular ulcer with rodent out of borders, that is have a indurated borders. Coming to leukoplakia, that has a white patch, and erythroplakia that starts as a red patch. Erythroleukoplakia, it's combined with white and red areas. It can involve gingiva, alveolar mucosa, buccal mucosa associated with beetle net placement. The tongue, it's a posterior, lateral and ventral surface. The floor of the mouth is more among the females and young age associated with secondary primary malignancy. The lips, most of them have actinic chelosis. The oropharyngeal, most the patients are unaware. The tumor size is greater and increased risk of metastasis. This is the picture of oral squamous cell carcinoma in the tongue, buccal mucosa and the lip. This is the cases of oral squamous cell carcinoma that occurs in the buccal mucosa, lip and lateral border of the tongue. Metastasis, the most inferior location, the larger lesion that increased the risk of metastasis, spread largely through the lymphatic vessels and epilateral cervical lymph nodes. Metastatic nodes are firm to stony hard in consistency. It is a non-tender and enlarged. In advanced stage of oral squamous cell carcinoma, the nodes are fixed and have a multiple nodes. The carcinoma of lip and oral floor of submental nodes. The posterior portion of the mouth, that is superior jugular and digastric nodes. The oropharynx, that is jugular digastric nodes and lateropharyngeal nodes. Coming to the stages of diseases, the stages mainly based upon the tumor size, extent of metastatic spread. It used to assess the prognosis and clinical outcome. TNM staging is widely used. T is for the primary tumor size, N is for regional lymph node involvement, M is for involvement by the distant metastasis. This is a primary size classification. The TX, no available information on the primary tumor. TO, that is no evidence of primary tumor. T1S, only carcinoma in situ at the primary tumor. And T1, that is a tumor less than 2 cm in greater diameter. And T2, that is tumor that occurs in the 2 to 4 cm in greater diameter. And T3, that is tumor is greater than 4 cm in greatest diameter. And T4, that is a massive tumor, the greater than 4 cm in diameter with the involvement of antrum, pericoid muscles and base of the tongue or skin. Regional lymph nodes, TX, the nodes could not be assessed. And NO, that is no clinical positive nodes were found. And N1, that is a single clinical positive homolateral node that is less than 3 cm in diameter. N2A, that is a single clinical positive homolateral node that is 3 to 6 cm in diameter. T2B, that is a multiple clinical positive homolateral nodes, none more than 6 cm in diameter. N3A, that is a clinical positive homolateral node, one or more than 6 centimeter in diameter. N3B, that is a bilateral and clinical positive nodes. N3C, that is a contralateral clinical positive nodes. Coming to the distant metastasis, M denotes for the metastasis, that MX, the distant metastasis were not assessed. MO, that is a no evidence of metastasis. M1, that is a distant metastasis is present. According to this, the TMN staging were found to find out the survival rate. So coming to the histopathology, the grading of tumor is done to assess the degree of resemblance to the parent tissue and protection of the normal product, that is epithelium and then keratin. It could be grouped into low grade, high grade and intermediate grade. The low grade, it's always a well differentiated squamous cell carcinoma. The high grade have anaplastic cells that's coming as a poorly differentiated carcinoma, and intermediate grade that is considered as a moderately differentiated carcinoma. Coming to the histopathology, we can able to see the dysplastic epithelium with the malignant cells in the connective tissue stroma in the form of sheets, islands and angiogenesis and inflammatory responses and hyperchromatic nuclei, keratin pearls and formation of individual cell keratinization. Here is the picture of well differentiated, it's more of keratin pearls, and moderately differentiated we can see individual keratinization, more of individual keratinization with mitotic figures and pleomorphism, hyperchromatism, and poorly differentiated, its number of mitotic figures will be increased in poorly differentiated. Almost all the tumor cells will be dysplastic, have a dysplastic features. So this is the epithelial islands. Here you can see the epithelial islands. It is in the form of sheets and cords. Here it is the picture of keratin pearl. Keratin, if it is the keratin pearls are present, this will be considered as a well differentiated squamous cell carcinoma. These are the keratin pearls. This is a picture of individual cell keratinization. There is a keratinization. It's called individual cell keratinization. This is a picture of individual cell keratinization along with the mitotic activity of a malignant tumor cells. Coming to the treatment of oral squamous cell carcinoma, for main is a surgery, chemotherapy and radiation therapy, and based upon the clinical staging and prognosis assessment. Recurrence can occur in oral squamous cell carcinoma because of improper management and recur at the same time and occurs at the different site and other than the primary tumor. It occurs as a distant metastasis also. Coming to another variants of oral squamous cell carcinoma. The verrucous carcinoma that considered to be a low grade, and spindle cell carcinoma that considered to be a high grade, and the adenosquamous carcinoma that considered to be a high grade, and basaloid squamous cell carcinoma that considered to be a high grade. Verrucous carcinoma, it is also called as a sniffer dippers cancer, that is Ackermann's tumor. That is a low grade variant of oral squamous cell carcinoma that first reported by the Ackermanns in 1948 in association with tobacco usage. It also occurs in the larynx, vagina, rectum, breast, axilla and ear canal and sole of the feet. It related to the HBV virus 16 and 18. It can be seen in this lesion. This is a clinical picture of verrucous carcinoma. Here you can see the verrucous proliferation, multiple verrucous proliferation. Clinically, in male older than 55 years, it most commonly occurs. In mandibular, it can be occurs in the vestibule, buccal mucosa and the hard palate. Often, it corresponds to the site of chronic tobacco placement where the tobacco pouch can be kept. So the diffused, well demarcated, painless and thick plaque with a papillary or a verruciform surface projection that clinically appears. It typically white in color. It developed as a component of proliferative verrucous leukoplakia. Coming to the histopathology, it's a benign microscopic appearance, wide elongated retiridges with push into the underlying connective tissue. It shows the abundant keratin protection and also shows the parakeratin plugging, the keratin that fills with the numerous clefts and crepes. The lesion shows the normal maturation, intense the chronic inflammatory cells infiltrate. So this is the histopathological picture. Here you can see the projection of verrucous kind of projections and in paraplugging, and you can see the elephant like retipex, bigger retipex, and the underlying connective tissue with the chronic inflammatory cells. So this is another case of verrucous carcinoma. Here you could see the parakeratin plugging, and then you can see the inflammatory cells in the underlying connective tissues. So the treatment of verrucous carcinoma, it's go for surgical excision without radical neck decision, and metastasis is extremely rare in case of verrucous carcinoma. This is considered to be a low grade malignancy. Coming to the spindle cell carcinoma, it is a rare variant with a dysplastic epithelial cells with an invasive spindle cell element. It considered to be an anaplastic type of cancer cells. The lesion cells have the ability to produce the mesenchymal intermediate filaments. It can occur as a recurrence after radiation dedifferentiation. Coming to the clinical feature of spindle cell carcinoma, it occurs mainly in the older age group. In the upper digestive tract, it involves mainly in the lower lip, tongue and alveolar ridges. It is a pedungulated lesion. It is a polypoid mass associated with pain and paresthesia. Grows rapidly and metastasizes early and travels along the nerves and lymphatic vessels. Coming to the histopathology of spindle cell carcinoma, you can see the fascicle of anaplastic spindle cells shaped along with squamous cells. You can see the numerous mitotic figures. We can confirm with cytokeratin expression by immunohistochemical analysis. Adenosquamous carcinoma, it's a rare variety and high grade. It's combination of adenocarcinoma in deeper region and surface with squamous cell carcinoma. The adenocarcinoma, it shows the glandular pattern with the mucus protection. It mainly occurs in the tongue, floor of the mouth and older age group are commonly affected. The metastasis to the cervical node is more common in this case. The radical therapy and poor prognosis. Coming to the another variant, that is basaloid squamous cell carcinoma. It is the rare variant of basaloid squamous cell carcinoma. It is a high grade aggressive in upper aerodigestive tract. It is most recently described as a variant in men, mostly occurs in the alcohol intake and tobacco intake patients. It involves in the base of the tongue and larynx. The cervical metastasis is more common in this case. Has a well differentiated and moderately differentiated and has a superficial epithelial cells and has an invasive basaloid epithelium with palisading peripheral cells with central necrosis. The treatment of this basaloid squamous cell carcinoma is radical surgery. Coming to the another variant, that is carcinoma of maxillary sinus. It's an uncommon malignancy. The weak association with tobacco use and strong relationship wood and leather dirt exposure. 3% of head and neck carcinomas occurs in the maxillary sinus. It remains asymptomatic and mimics the sinusitis for longer period and fills up the sinus. Usually the squamous cell carcinoma, the disease of elderly patients, the male predilection is more. 80% of the cases is advanced stage, the stage 3 or stage 4 at the time of diagnosis. The nasal stiffness or a oral ulcer or mass of a hot palate and the alveolar bone. The intense pain or paresthesia that mimicking the toothache. The loosened tooth that mainly occurs in the maxillary region and giving an appearance of moth-eaten appearance, have a cloudy sinus appearance in the CT and MRI. The cervical and submandibular lymph node metastasis that can occur. In histopathology, it can resemble like a squamous cell carcinoma, either moderately or poorly differentiated. Main treatment of this condition is a radical surgery and radiotherapy. Coming to the another variant, that is nasopharyngeal carcinoma. It is arising from the lining of epithelium of lymphoid tissue, that is a rich nasopharynx. It involves the lateral pharynx wall. It shows the cervical lymph nodes enlargement. That is an aggressive tumor with 3 variants. That is the keratinizing squamous cell carcinoma, non-keratinizing squamous cell carcinoma, or undifferentiated non-keratinizing squamous cell carcinoma. Coming to the basal cell carcinoma, it is also called rodent ulcer. The most occurs in the skin cancer. It locally invasive, slowly spreading from the primary epithelial malignancy. It is arising from the basal layer of the skin in appendages. In 80% of this case, it occurs in the skin of head and neck. It results of a chronic exposure of UV light. It is treated by surgery. Clinically, it occurs in the white people. It has a 5 clinical forms, that is a nodule with a central abblication, telangiectasia vessels on the borders. Okay, the pigmented lesion, that is an uneven melanin pigment that can be seen in the pigmented type of basal cell carcinoma. Sclerosing type that resemble like a scar clinically. In superficial, that is a multiple lesion. An association with nevoid basal cell carcinoma syndrome is most common associated with basal cell carcinoma. Coming to the histopathology, you can see the uniform ovoid dark staining basalite cells with moderate sized nuclei and little cytoplasm, well demarcated islands and strains that inverting into the connective tissue. The palisading of peripheral cells that are surrounded by the clear zone. Coming to Meckel cell carcinoma, it is a rare aggressive primary malignancy with neuroectodermal features. In older people, it occurs in the sun exposed skin. Dome shaped nodule with a smooth surface of telangiectasia blood vessels that is infiltrating the sheaths and gauze of moderated size undifferentiated basophilic cells. It has a numerous mitotic figures and intercytoplasmic granules. Coming to the melanoma, malignant melanoma, it's also called as a melanocarcinoma. It has a melanocytic origin that is arising from the benign melanocytic lesion. It is also from the melanocytes of the normal skin or mucosa. It more occurs in the skin. It's caused by UV radiation. Main etiology of this malignant melanoma, it is from the UV radiation and sun exposure. And more incidence, the light complexion of people has the approach equator. The acute sun exposure than the chronic. It is greater importance of malignant melanoma. The oral lesion, there is no relation to the sun exposure, and third most common skin cancer with a high mortality rate. The mucosal melanomas are common in head and neck area. It is followed by the rectal and uro. And mucosal melanomas, the aggressive than the cutaneous. It has a genetic alteration of BRAF protein kinase. Clinical feature of malignant melanoma, it occurs mainly in the white adults and mainly in the 50 to 50 years of age. And there is a specific clinical features for this condition of melanoma, that is A, B, C, D, E. A denotes for asymmetry, and B border irregularity, and C the color variation, and D diameter greater than 6 mm, and E that is evolving. Color variation that can be a brown, black, white or red and blue. The evolving is change of the size, shape, color, surfaces and symptom over the time. Mainly the malignant melanoma has a 2 different growth phase. That is a radical growth phase, that malignant melanocyte spreads horizontally through the basal cell layer of the epithelium, and vertical growth phase, the malignant melanoma that inverting the underlying connective tissue. Coming to the clinical features, it occurs in white adults. It has 4 types, and superficial spreading, nodular, lenticulomaligna and acral lentinosis. So the oral finding, it often occurs as a nodular type of growth. It occurs in the 6th to 7th decade of the life, and male it shows the predominance. It mainly occurs in the hot palate and maxillary alveolus, and brown to black macules with irregular borders with lobular and exophytic mass that develop within the vertical growth phase. It is soft on palpation and moth-eaten destruction will be seen. Coming to the histopathology of malignant melanoma, you can see the atypical melanocytes at the epithelial and connective tissue junction. Here you can see the junction of epithelial and the connective tissue. You can able to appreciate the melanocytes, black color pigmented cells. These are the cells are larger than normal melanocytes with varying degree of pleomorphism, hyperchromatism, and it gives the pagetoid spread. It's seen as a superficial spreading of melanomas. The invasive melanoma cells that appears as a spindle shape or epithelioid are arranged in the cords or sheaths. The invasion into the blood vessels and lymphatics are more common. And few oral melanomas that can be seen in bone and cartilage and misdiagnosed as a adenoma, pleomorphic adenoma or osteosarcoma or mesenchymal chondrosarcoma. Some cases do not express the melanin within the melanocytes. That's called amelanotic melanoma. IHC is mandatory for this kind of condition. The IHC for S-centric protein and MART1 and HMB45 to confirm this diagnosis. Coming to the treatment and prognosis, the clinical staging it based upon the TNM and histopathological staging it based upon the two system, that is Clark system. It assigned the level is based upon the deepest anatomic tissue and invade into the tumor cells. Breslow system that measure the distance from the top of the granular layer to the deepest point of the tumor inversion. The surgery with the radical neck decision and prognosis is extremely poor of this condition. The most of the patient usually die due to the distant metastasis. This is the pictures of class and grossal depth. Here you can see the stage 1 to stage 5. You can appreciate the infiltration of the melanocytes from the stage 1 to stage 5. The treatment and prognosis depending upon the classification. Either the cells is confined to the epithelium or it is proliferating to the papillary dermis or extending to the reticular dermis or it is extending to the subcutaneous dermis. So the treatment and prognosis depend upon the level of infiltration of the melanocytes. Thank you for watching.